All right, thank you so much, Tim and Rhonda, for the wonderful introductions. We're really excited to have you here today. And what I would like to do is introduce our first keynote presentation of the day, which is by Dr. Brandon Crawford. So to give you a bit of an introduction, I think it goes without saying that no brain injury is easy. They all affect the family unit and require a tribe. In this presentation, Dr. Crawford's objective is to really help educate loved ones and caregivers about what is going on inside the head of a brain-injured child and offer some strategies to help and support them. So as an older sister myself to someone with a brain injury, I think this is going to be a really phenomenal presentation. So thank you guys for being here, and over to Dr. Brandon.
How's it going? Hey, David, while you're keying that up, I think we ought to just open up in prayer, if that's okay with everyone. Cool. So, God, I just want to thank you for today. God, I want to say that I wish we didn't have to be here. But God, I know that all things work together for your glory and for your good, God. And so I thank you. I thank you for today. God, I want to acknowledge that all healing comes from you. And that when I stand up here and I talk about whether it be functional neurology, whether it be laser therapy, whether it be H-spot or stem cells or whatever it may be, that God, we acknowledge that all healing comes from you. And we're nothing but vessels. So God, I pray that we can feel your presence today. And again, I thank you and I love you in Jesus' name. Amen. What you got, my man? We're all waiting on David now. While we're waiting, we can chant "Let's Go Brandon" if you would like. Okay. So, you didn't play my video, man. You let me down, but that's okay. No, don't worry about it. Don't worry about it. We're good. All right, so, Kevin Oates, where you at? Come on up here, my man. Come here. Okay, so I've had the pleasure to work with the Oates family. Isaac is phenomenal, okay? What a lot of people don't realize about you is that you're an expert polar bear hunter.
Yes, I am.
Yeah, and so here's the thing. Kevin has a surefire way to catch a polar bear.
Yes, absolutely.
Can you please share with the crowd?
Okay, so I was taught this method by a friend of mine from work, and so how to catch a polar bear. So the first step to catch a polar bear is you you go up to the North Pole and you cut a hole in the ice. So whenever you have the hole in the ice, and then you take peas and you line the outside of the ice hole with the peas, so that way whenever the polar bear comes along and he stops to take a pee, you kick him in the ice hole, and that's how you catch a polar bear.
Thank you. We're gonna go try that later this year.
Try it. Yeah.
Fantastic. Okay, that's amazing. Thank you. I appreciate your insight. That's good stuff, guys. Okay, so like she was saying, the goal of this presentation is to educate. I debated how I wanted to present this information, and I want to go to a pretty high level because this group of people, like, you want knowledge, right? You want knowledge, and honestly, many of you are more educated than the average physician. You're more educated than even some specialists. So that's what I want to do. I want to give you a high level of information, but I want to bring it down to where you can understand it, and to where you can digest it. And what I want you to do is be able to walk into a physician's office and actually challenge them. Because this is your child, right? This is your child, and you are their advocate. So I want to arm you the best I can, okay? So this is me. Now, when you see all these things up here, here's the goal of all of this. My goal is to make developmental functional neurology the gold standard of healthcare. That's what we're doing. And so we're trying to have a global impact, and we're doing it. Because I truly believe that developmental functional neurology is the most innovative form of healthcare on the planet. I do truly believe that. Do you understand? And here's the thing. The brain controls everything. It controls the immune system. It regulates our autonomics. It does everything, okay? It's not just the brain. The brain is everything. It's our perception. It's how we think. It's how we feel, right? So if we can understand the brain and know how to apply that information, then it can be completely life-changing no matter what, no matter if it's a brain injury or whatever it is, okay? So here's part of our team with Luke. Luke is a legend. And so I have a consulting service, and what we tell people is we want to make you legendary. That means we want you to make a ripple throughout time, something that transcends time, right? Luke has done that. And I just applaud it. And again, I wish it didn't happen, but Luke is legendary. What he's done has affected so many. And I'm so honored to be a part of it. This is Ford. Now, I wanted to take a little bit of time because I was not able to actually travel to Ford's service. So Ford was really close to me. I was really close to Ford. If any of you knew him, he was a warrior. He was a fighter. So he wasn't the first brain injured child I worked with, but they were the first ones that really came and they dug in. They spent a month with me. They didn't even know who I was. They didn't know anything about developmental functional neurology. And the cool thing about Ford is that he had a mama that was very quiet and meager, if you know Sabrina, right? You can laugh at that, okay? I know Sabrina. She's a friend. So Sabrina told the world about this thing called developmental functional neurology. It was fantastic. And so, guys, like, this little baby, he did so much for me. I learned so much from him. Okay. This is what Kaysen thinks of pediatric brain injury, by the way. So, yeah. So, that was Kaysen. That little dude was kicked in the head by a horse, and he came in. He couldn't move. He couldn't talk. And he hates our swing. He hates doing anything vestibular. And I said, Kaysen, I'm going to put you in that swing. And if you want to cuss at me when I put you in that swing, you can do that. So I put him in the swing, and I turn, and he's giving me the finger. And I'm like, oh, man, that little dude, he's amazing. All right, so goals for today. We need some community development. I'm here to provide you answers, as is everyone else, okay? Please come and talk to me, okay? Please don't be shy. Come and grab me. Come talk to me. I'm here all day. I'm here for you. So come grab me. I'll be in that room. I swear, when I walked in, I'm like, holy crap, they put me in a room. What, do they not like me? Am I too loud? Is it the fart jokes? What is it? So I'm in a room over there, so come talk to me. We're here to provide hope. In the lecture, I do really want to focus on anoxic brain injury for a bit, and that's because anoxic brain injuries are tough, okay? And I'm telling you, like, if I'm working with someone that's, had just a blunt force trauma, a diffuse axonal type of brain injury or something like that, man, we got that down. And we've had that down for years in functional neurology. We have all the different healing stages and strategies and all that thing defined, but anoxic brain injury is different. It is way more difficult. So what I want to do is give you the overview, because there is literature out there that tells us more specifics about the injury, the lesions, the locations, and what to expect. And from that, we can develop strategies, right? But I want to also talk about how we can apply this to all types of brain injury, okay? Okay, so let's get into it. So what is anoxic brain injury? Well, it's basically whenever there's lack of blood flow to the brain. You have lack of blood flow, and that can happen in many different types of ways, right? Now, when we look at the research, or when we look into the literature, cardiac arrest is going to count for the majority. And I have treated babies that have had cardiac arrest. They call it spontaneous or idiopathic, or maybe there's an underlying factor like an autoimmunity or whatever it may be, maybe an infection. but cardiac arrest is actually the prevailing factor. Obviously, another prevailing factor here, especially in pediatrics, is near fatal drowning. So we're going to talk about that, okay? So this is just on cardiac arrest. The incidence of emergency medical services assess cardiac arrest in the adult population is 347,000 per year. That's just adults. And here's the sad thing, no one really knows what to do with them. They say, hey, you got a brain injury, your heart stopped, good luck. Don't go do HPOT, that stuff's wacky. Although, you're lacking oxygen in the brain, wouldn't that make sense, Dr. Harch? I mean, it just makes sense. Anyway. So, what are some mechanisms involved, okay? Now again, I want to give you this knowledge, I want to give you the information, you're going to have access to my slides, and I'm going to talk you through it. But again, I want you to go into your doctor's visits, and I want you to kick their butt, okay? So, primary mechanisms involved. There's two primary mechanisms of injury with ABI, primary and secondary. During the primary injury, there's first ischemia, or lack of blood flow, okay? And then there's subsequent reperfusion. During the process of the brain ischemia, there's anoxic depolarization. So there's like a lot of misfiring, right? So our ion channels get imbalanced and those neurons just start firing. They start misfiring. ATP depletion, so energy levels start to go down. Glutamate release, which can become excitotoxic. Free radical formation, nitric oxide production. The primary injury causes considerable neuronal damage, but the successive reperfusion accounts for substantial cerebral ischemia and cell death. Despite the return of spontaneous circulation during cardiac arrest, there is a brief period of hyperemia that is quickly replaced by a longer period of global and multifocal hypoperfusion known as the no reflow phenomenon. So basically, there's this damage, and that damage causes central mechanisms that then you can't regulate your autonomics and provide adequate and balanced blood flow to the rest of the brain. That's the no reflow phenomenon. So you have this kind of vicious loop of events that continues unless you initiate something, some kind of strategy to mitigate it. And again, here's information about anoxic depolarization. We have loss of neuronal selective membrane permeability and the ion gradients across the membrane that are needed to support neuronal activity. So basically, these ion gradients become imbalanced, and we start, like I said, getting misfiring, which leads me into another discussion of seizures. So I want to just take a moment and really just talk about seizures. And specifically, I put on there a discussion with Asher Bevan's parents because it was shocking what they told them, what their physicians told them. And I hear these stories all the time, right? So, basically, I'm sitting there in the office, and Asher Smasher's parents said, hey, what do you think about Asher's seizures? And I was like, it's very similar to all the other types of seizures I see, and we kind of talked about the things that we already talked about. And they read me this email from their physician who specialized in cerebral palsy, apparently. And it went on, and it was one of the most aggressive, just downright, almost negligent email I've ever read. I mean, how can you sit there and describe seizures in a child and then tell the parents that it has a high level of mortality and, there's nothing that can be done and there's no hope, but by the way, we don't know where these seizures are coming from. How can you draw those conclusions and then turn around and say, but we don't really know where these seizures are coming from? Well, first of all, let me tell you where those seizures are coming from. You understand? So, there's a study going on right now in Cuba. It's being led by my colleague, Dr. Robert Melillo. And the study was initially looking at our developmental functional neurology exam procedures. We're trying to see if our exam procedures correlate with the areas of underdevelopment or lack of integration in the brain. And not only does the exam correlates very highly, but they also found that whenever we can identify the area of the brain, the weakness, the lack of integration, the whatever you want to call it, there was a level of paroxysmal activity in those networks. So what is paroxysmal activity? Paroxysmal activity is underlying abnormal electrical activity, okay? They can spike up in the seizures. Medical literature says we don't know what causes paroxysmal activity, so good luck. So that's cool that we were able to consistently identify and predict where those areas of paroxysmal activity were going to be. Now, the second part of the study is rehabbing those areas, very specifically in being targeted about how we do this, which is what developmental functional neurology is all about. And the cool thing is, as we began to rehab these networks, the paroxysmal activity then would go away. Well, that's never been identified before. So not only can we identify it, but we can make it go away. Now, during the time of rehab, okay, you'll see seizure activity. And it was very consistent that you would see some seizure activity happen. So why is that happening? Well, think about what I just say. There's anoxic depolarization. There's this misfiring in the neurons. So if we have paroxysmal activity and we start to ramp up the amplitude and the frequency of firing of the neurons, we're trying to grow and develop a brain, right? A brain needs to fire with enough amplitude and with enough speed that it can produce normal function. So if we're doing this, we're doing it correctly, the brain has to calibrate. It also goes through phases of pruning, which is a whole nother discussion. And so that, again, we can consistently identify paroxysmal activity and seizure activity, and then it goes away. And so for the first time in medical literature, we're identifying these things. So here's the thing. Seizures happen in these cases. They do. I'm sorry, they just do. But here's the thing, the brain will never give up. The brain will never go, well, I guess I'm just injured, I'm gonna stop here. That's not how it works. The brain will always try to develop itself. We have these inborn mechanisms which we're going to define. And as it does that, it has other mechanisms that it has to calibrate itself, and like pruning and these types of things, right? And so go in armed with that information. Now, the study I referenced is not published yet, okay? It's still going on. They tripled the size of it because it's a very important study. But once it does come out, it's gonna be huge. It's gonna be huge for this population especially, okay? All right, that's just for my left brain people that need this stuff bullet pointed out. There you go. All right, secondary injuries, right? Secondary injury consists of ongoing ischemia, autoregulatory failure. That's where I'm saying that you get this autonomic dysfunction and the brain cannot control that blood flow very well. Cerebral hypoperfusion, blood-brain barrier breakdown, which is a big problem. That barrier around your brain starts to break down, and this can lead to things like autoimmunity, inflammation. We get infiltration of things like viruses and bacteria and things like that that the barrier system should keep out. So this can be a pretty severe problem. Seizures, like we just talked about, oxidative injury, and hyperpyrexia, which we're going to talk about when we talk about storming. Okay, and again, that's for my left brainers. I threw this in just for some more information for you. Okay, so let's run through some most common areas of damage, because when there is an anoxic event, we can consistently see damage in specific areas of the brain, like the hippocampus, the cerebellum, the cortex, the thalamus, the striatum, which is the basal ganglia. And then we're going to talk a lot about our vascular border zone areas, or our watershed areas, okay? Hang with me, okay? Everyone's getting, do y'all need another joke? Kevin, you got another joke? Oh, okay. Notice, that's why I'm not saying a joke. Y'all know how to tell a male from a female snowman? Snowballs. All right, moving on. So again, we have hippocampus, right? This has a lot to do with memory formation. The hippocampus actually help us navigate our spatial, with spatial navigation. The cerebellum coordinates everything in the body. It coordinates our muscles, coordinates our immune system, coordinates our inflammatory pathways to a certain degree. So it's all about coordination. The cortex obviously is our executive skills. The thalamus is a big relay station for sensory. And the basal ganglia, or the striatum, is going to be our amplitude of movement, along with lots of other things. Okay, so we're going to get into this a little bit more. So, what happens when these areas are injured? I listed this out. We don't have to go into this. But look, I do want to talk about simultagnosia just a little bit. Simultagnosia happens whenever you can only really process one thing at a time, right? And so what happens is I'll start seeing a patient and they're like, we don't think they can see. Well, it's hard to understand what they can and can't see, especially if they can't talk to us, right? But this thing about simultagnosia happens, and it's basically you can only perceive and process a limited number of things at once. You understand that? So that can happen in this population. And so understanding that and knowing that sometimes we just need to slow down. Like for example, when we were working with Johnny Grant, okay, I'm sure everyone knows about Johnny Grant. If you don't, you can follow Laura B. Pilates on Instagram. He got very frustrated because we were trying to get him to perform tasks or respond to cues, but we didn't give him enough time, right? And so he was getting frustrated. And so when we're retraining someone about how to walk or talk or acknowledge things, be sure you give them adequate time to respond because their processing speed is slower. It will speed up, but it can be very frustrating to someone who's sitting there. You ask them something and then they're still processing it maybe a few minutes later, and then you might see them initiate a movement or initiate a word or something like that, right? So understand that idea. And you know, when you go to your doctor's visit and they spend 15 minutes with you and you know, they say, well, okay, they have CVI and you know, can't move, okay, good luck, see you later. Was that enough time to properly evaluate someone? No, it wasn't. More information there. More information there. Again, I wanted to load these slides up with information for you because you're going to have access to them. Okay, so let's get into some non-fatal drowning. This is my buddy Forrest. So, most common ages, 1 to 4 years old, 2 out of 3 survive actually. Most common location, swimming pool or natural bodies of water. Males have twice the mortality rate than females. Some report 80% of drownings are male, okay? This is a study that if you are treating brain injury and you're out there listening, I want to point to this and highly suggest that you read it. It gives a lot of good information. But look, here's what I want to draw your attention to. Structural neuroimaging modalities like CT and MRI have been of limited clinical value. Limited clinical value. We understand that because everyone's coming in and the doctors are going, oh my God, the CT, this MRI, this is absolutely horrendous. Your kid's going to be a train wreck. And they're like, the kid's, you know, way better than they would ever anticipate. Or just the opposite. Oh, we see minimal damage. You're going to be fine. But then there's limited function. It's because of this. And again, it's of limited clinical value. So if this is even stated in the literature, why are we leaning so heavy onto that? Now, I understand the need to do it. But why weigh in so heavily on these modalities for therapies and for outcomes if we're even being told that it is of limited clinical value? Here's some information that the gray matter is affected more than the white matter. However, I am looking into this, and that may or may not be true, but basically the gray matter is more metabolically active, therefore it requires more blood flow. But the white matter is like your highways, right? So I talk a lot about the posterior limb of the internal capsule. This is all the bundles of fibers coming down from the brain, like the highways carrying the signals down. And we do see a high level of injury, especially with like locked-in syndrome, to the posterior limb of the internal capsule, or just the internal capsule in general. So this is in the study, but I do think we do see a lot of white matter injury as well. Again, we see the basal ganglia, we see the thalamus, there's the PLIC like I just spoke about, and subcortical lesions. Something that is very consistently affected is the lenticular-striate vascular distribution, or the lenticular-striate vascular watershed. And I've got a picture that I'm going to use to discuss that more. So when you look at this, right, here's what I want to point out. We have all these little bitty arteries in here, okay? All these little bitty areas in here. There's the lenticular-striate watershed through there. Why would this be more affected than the big arteries, right? Well, it's because they're tiny little capillary beds. And so if you restrict oxygen or you restrict blood flow, those areas are going to be more prone to injury, okay? You understand that? So if we understand that, then we can really start to target therapies to those regions. So how do we do that? Well, how we do that is we have to understand how to activate the brain, because if I can start to make cells fire, they're going to require more blood flow. So there's mechanisms in place where they start signaling for more blood. They start signaling, going, hey, we're trying to fire, come feed me, right? So that's why this is so important. Okay. Deferentiation syndrome. So the descending cortical, spinal, and cortical bulbar fibers pass through the PLIC, which is, again, the posterior limb of the internal capsule. And if any of you have been in my office, I love to draw. So this could have been a 4-hour presentation because I'd be drawing all this stuff. And it's so hard for me to talk about it and not draw it. But basically, your cortical spinal pathways come down from your cortex. That's your brain saying, I want to walk, I want to talk, I want to move, I want to do these things. And it sends all the projections down to all the networks underneath it that make all these things happen, right? And so the cortical spinal and the cortical bulbar fibers come down from the brain through that posterior limb of the internal capsule, okay? And what we can see is when that area is damaged because of its proximity to the lenticular striate watershed, we can have a selective deferentiation syndrome with disproportionate motor impairment and relatively preserved perceptual and cognitive function. Now, we're going to harp on this for a little bit because it is a topic that I've had great interest in over the past 2 years, okay? So, like I said, we have a selective motor system impairment with relative preservation of perceptual and cognitive function in children with post-drowning anoxic brain injury. Collectively, these observations suggest that there's substantial motor deficits in these children. All are quadriplegic and most are aphonic or cannot speak, arising from structural damage to the basal ganglia and posterior limb of the internal capsule, and from functional compromise of the basal ganglia and cerebellar networks, effectively prohibit full expression of their level of awareness and cognition. I'm not making this up, guys. This is stated in the literature, okay? So, when you're in a doctor's visit and they say, well, your kid can't move and they're not responding, so they must not be there, it's a load of crap, right? You know your child. You know your child better than anyone, better than that physician, better than any therapist, better than me. And you see it in their eye. You see it in them. You know they're there. I'm telling you, there's a large chance that they're there. And it's stated in the literature. I'm not going to tell you something that I can't back up. Okay? Again, okay? Effectively prohibits the full expression of their level of awareness and cognition. Okay? Autonomic dysfunction associated with locked-in syndrome. So, what we get in the child or the adult that is storming, right? We get this hypothalamic storm. This is unbearable. This is the most heart-wrenching thing for everyone involved. It's so sad. But basically, we get this autonomic dysfunction syndrome characterized by hyperthermia, so they're very hot, they have a high heart rate, high blood pressure, they're breathing fast, their pupils are huge, they have increased extensor tone and posturing. Why does that happen? How come when you're storming you go into this extensor tone and you can have either this presentation or this presentation depending on where the main lesion is? But basically, you know that cortical spinal pathway I was just talking about. You lose inhibition of the cortical spinal pathway coming down and inhibiting the vestibulospinal pathway. The vestibulospinal pathway likes to take you into extension. And so instead of having a balance between those two networks, you just go into extension, right? And so that's that extension state. Now it can come and go. And again, we're going to talk about that a little bit in regards to the vagal system, okay? They become very sweaty, that's a diaphoresis, okay? And again, head scans indicate hypothalamic mesencephalic dysfunction. The mesencephalon is the midbrain area, that's where those basal ganglia live, closely related to that lenticulostriate watershed area. We doing okay? Picking up when I'm laying down? Smelling when I'm stepping in? All right, good. So, here we go. Some more fun words. We have substantial preservation of the sensory motor, visual, auditory, and default mode network in the patient group. So we have these networks in the brain. The default mode network is like our attention, our awareness, has to do with joy. It's more connected to like dopamine and that kind of stuff. Less preservation was observed in the left frontal parietal, frontal lobe, parietal lobe. Frontal lobe's more movement-based, some executive skills, eye movements. Parietal lobe also has eye movements, and it's how it feels the body. Right frontal parietal and executive networks. The least preservation was observed in the basal ganglia and cerebellar networks. So again, basal ganglia controls the amplitude of movement, and the cerebellum coordinates everything that we do. So again, it coordinates how we move, it coordinates how we talk, it coordinates how we think. 80% of the cerebellum is dedicated to coordinating our thoughts. Okay? It coordinates our immune system, coordinates our inflammatory pathways. It's really cool. So those networks, basal ganglia and the cerebellum, are consistently damaged in this population. That's saying the same thing there pretty much. And here's some pretty graphics from the study, just reiterating what I just talked about. Motor intrinsic connectivity networks, the basal ganglia, cerebellum, were grossly compromised, striking preservation of perceptual, visual, auditory, sensory, motor, and cognitive intrinsic connectivity networks, like the default mode, deferential parietal, executive functional function, were observed. Okay, that's amazing to read because again, doctors that don't understand this and they just spend 15 minutes with your kid, they don't understand this and it's just terrible, right? So collectively, our findings indicate that the severe motor deficits observed in this population can mask relatively intact perceptual and cognitive capabilities. That slide should go into the emergency room. That slide should go into the neurology wing, right? This is a big concept that most docs are not understanding. Okay? I wanted to talk about, okay, good, some compounding factors for locked-in syndrome. This is really what I've been looking heavily into over the past few years, trying to make sense of this whole storming situation and what's going on and how does it connect and how can we rehab it? Because that's the thing, I don't want to just understand it, I want to fix it. I want to improve life. That's the whole point of doing what we're doing, okay? I loved being a diagnostician. I love it. I absolutely love it. But I want to help people, right? I really want to improve life, okay? So let's talk about this. So if you come into my office, I like to draw on windows. I get bored, and so I just start drawing pictures. No, I'm just kidding. So when I'm talking to someone, I try to explain it best I can. And so we have this system in us called the vagal system. It's connected to the vagus nerve. Does anyone heard about the vagus nerve? Yes? Yes? Good. 3 of us have heard about it. That's fantastic. Okay. So to fully understand this idea, this concept, we have to understand it from a developmental perspective as well, okay? Because this whole story is based around something called neuroception, which constantly evaluates risk, okay? So when I walk into the room, neuroception is subconsciously at play. I'm walking into a room and I'm going, hey, it's Cody. He's not mad at me, he's just ugly. Hey, it's Kevin. He's not a threat. He can't catch me if I run away from him. So, right? I mean, so it's constantly just subconsciously evaluating the room, okay? It's doing this for safety, okay? So that's neuroception. Now, what develops in the womb is something called the dorsal vagal centers. This is connected to the fear paralysis reflex. This is playing possum. And so what happens is, in the womb, and up to about 6 months, we can't really move. And so if there's a life threat, we shut down. We shut down to preserve our metabolic integrity, to preserve oxygen. We reduce our metabolic demand on our brain and our organs so we can survive. So this is that possum that gets so scared it plays dead. We have that mechanism in us. Okay, so that's our dorsal vagal centers. And then what happens is we develop our sympathetic nervous system, and it will inhibit that dorsal vagal center, and it will say, hey, dummy, don't play dead, run away or fight. And so we develop our sympathetics. This is that fight or flight system that everyone is in all the time, right? Now, these are all connected to primitive reflexes too. The fear paralysis is a primitive reflex. The Moreau and the startle is more connected to the sympathetic nervous system, okay? And like I said, this system will shut that down and say, get up and run away. Then we develop our ventral vagal centers. This is the newest, most efficient part of our vagal system. And it says, hey, I'm going to read that face. I'm going to listen to the tone of their voice. I'm going to see how they're talking with their hands. I'm going to read this situation. And I'm going to shut down the sympathetic nervous system too. And I'm just going to engage with this person, right? So that's where we want to be. Now, I tell you all that to tell you this. The ventral vagal system is largely comprised of the nucleus ambiguus, and the nucleus ambiguus is comprised of cranial nerves 5, 7, 9, 10, and 11. That's really important because 5, 7, 9, 10, and 11 then become factors or therapeutic strategies to rehab the ventral vagal system. Because if we have this scenario where someone drowned and they're starved for oxygen, and so they default into their dorsal vagal centers and they shut their brain down, they shut their body down, okay? This is also what can happen if you get hit in the head. This can also happen if you're in an abusive relationship. This can also happen if you have trauma from taking care of a traumatically injured person, right? You can start to fire this fear paralysis reflex. And instead of shutting down, it might look like unrelenting anxiety, might look like chronic fatigue, or something like that, right? So you have this individual that is in a life threat scenario, so they shut everything down, okay? That gives us a scenario where we shut down and we see part of this locked-in syndrome really come out and come into play. Does that make sense? Okay? So then, this is developing rehab strategies. That's why I'm talking through it. Now we have all these other complicated things up here, like the prefrontal cortex. The medial prefrontal, or the medial frontal lobe in the prefrontal cortex actually fires directly through the thalamus into the amygdala, and will shut that process down. The amygdala is part of the limbic system. The amygdala only has emotional memories. The amygdala is not linear, logical. It just remembers emotions, right? And again, it's good that we have this, otherwise we wouldn't be here and we wouldn't have survived as long as we've survived. So think about this. If a spouse tragically dies and everyone sends flowers to that spouse, fast forward 5 years later, the other spouse that's still living all of a sudden has anxiety and they don't know why. It's coming out of nowhere. Well, every morning that spouse takes a walk. And on that walk, they subconsciously see all the flowers in everyone's garden, and those flowers are being connected to that traumatic event by the amygdala. And so then the amygdala fires into the sympathetics and says, what the heck, man? This is bad. Last time we came in contact with these flowers, it was terrible. But there is cortical integrity, and so the person goes, well, I'm not going to run away. I don't know what I'm running away from. And so it goes, fine, idiot, then shut down. And so then they get chronic fatigue and anxiety, and that's the fear paralysis coming out. You kind of understand how that's happening. Now, the amygdala is very efficient. It has some of the fastest and most efficient neurons firing from it into these systems called spiny neurons. That kind of sucks. Again, it keeps us alive, but it takes some large networks like that prefrontal cortex, cerebellum, and the vestibular system to fire into them and give some context to the scenario, like the prefrontal will say, no, those flowers are just there, it's your dumb neighbor, don't worry about it, it's not connected. Or it requires other networks like the cerebellum and vestibular system to shut it down, okay? So ultimately, see, I'm going somewhere with this, guys. So ultimately, if we can fire cranial nerves 5, 7, 9, 10, 11, we can turn on the prefrontal cortex, the cerebellum, and the vestibular system, we can shut all that crap down, okay? And that's why I shock Isaac's face. And that's why we stem the symbicontia. And that's why we do these things, right? So let's talk about that. That's all just pretty pictures of what I talked about. So, vagal system rehab. This is stuff that you guys can start doing at home. You know, if you have a kiddo and some of this stuff is jiving, you're making sense. You know, you remember why, okay, male snowman have snowballs, I get it. Then we can start rehabbing the vagal system, right? So, again, we can vibrate the abdomen. We can stimulate the Moreau, because remember, the sympathetics inhibit the dorsal vagal centers. So we can stimulate the Moreau. We can take someone back real quick. We can flip them backwards, like that reflex when you're laying a baby down in a crib and their arms fly out and their head extends. That's the Moreau. We can use lights. We can flash lights in the side of their periphery. We wear eye lights in the office that have colored lens and they flash at them, right? That's part of stimulating the Moreau to shut this system down. We can use sound, okay? So this system's highly connected to light and sound. Cranial nerves 5 and 7, we can stimulate the face. We can vibrate the face. We can contract the muscle with electrical stimulus or other means. We can use taste. Taste has a huge imprint on the brain. It actually can magnify whatever neurological rehab you're doing. It touches so many different networks in the brain. So we use taste a lot. Cranial nerves 9 and 10, we can stimulate the tongue. We can use our gag and gargle reflexes. We can stim the auricular branch of the vagus nerve via an area called the symbicontia, one of the most powerful things that I've seen in neurology from a single modality, okay? We have cranial nerve 11, which is our traps and our SEMs, and you notice as I'm talking, I'm sitting here and I'm moving my shoulders, I'm moving my hands. That's part of this. That's part of my vagal system interacting with you, letting you know that, hey, I'm here and I'm okay and I'm safe and all these things, right? Then we have social engagement, right? So we have someone like Katie that can talk to someone as they're working on patients. So that social engagement is super important too. So when you're working with your child or your loved one or whoever it may be, talk to them, engage with them. They can hear it, they're perceiving it. Neuroception happens at a non-cognitive level, right? They don't have to be responding back to you or even really seeming like they're responding back to you. And you have that slide, okay? Some other considerations are spinal cord considerations. When we have brain injury, I think that the spinal cord is actually something that's really overlooked. So how this works is like this. The brain says, I want to move. Here's what I want to do, and it sends the information down. And the cerebellum goes, great. I have something called fixed action patterns where I've already mapped out all the muscles I need to move in order to do that, whatever you want to do. And so I'm just going to then take the information and shoot it down to the body. We're going to do it. Thanks, cortex, I got this. And then it sends it to the basal ganglia and goes, hey, basal ganglia, here's how we're going to do it. Here's all the muscles and here's all the things and all the trajectories and all the things. And the basal ganglia goes, great, I'll control the amplitude so you don't walk around with all these jerky movements. I got it, I got this. And then it sends it down to the spinal cord. And this is where I think the spinal cord should get a better reputation. Because the spinal cord goes, dang it, you sent me a lot of information, you bunch of jerks. So now the spinal cord has to wrap up all that information and put it in these things called central pattern generators and go, okay, the cerebellum says we're going to move these 507 muscles. The basal ganglia says to move in this amplitude, and the frontal lobe says that we're going to go in that direction. So keep all this moving for me. And so those central pattern generators are sitting there and keeping it all going. All your rhythmic movements are coming from these central pattern generators. So whether we're walking, we're talking, we're breathing, we're swallowing, all these things are controlled by the central pattern generators. This is why we laser the spine. This is why chiropractic actually kind of works. Oh my God, did you just say that? Here's a cool study looking at cortical spinal motor circuit plasticity after spinal cord injury. Okay, this is looking at photobiomodulation. So we can beneficially harness the neuroplasticity of cortical spinal motor circuitry. Represents a highly promising therapeutic approach for improving locomotor outcomes after spinal cord injury. And again, we're looking at photobiomodulation. I've had several spinal cord injuries respond extremely well to lasering the spine and doing these functional neurology modalities. It's fantastic. But I think in this population, whether you got slammed in the head, whether you drowned, because hey, there's little capillary beds in the spine too, right? And so we can have abnormal movement patterns, abnormal rhythmic movement patterns can be from these central pattern generators as well. Okay? And something else I wanted to talk about is this idea of network efficiency and conditioning, right? So everyone knows about neuroplasticity, right? We all know about neuroplasticity. So I talk about neuroplasticity like we're forming a river, okay? So if we wanted to make a new river, we need a lot of rain. So we can start to rain into these little creeks and whatever, and they start to form, but then if it stops raining, what happens? It dries up, right? Okay. But what we want to do is we want to flood into these things until we get like the Mississippi River. Because it cannot rain over the Mississippi for a long period of time, and it's still going to keep flowing. That's efficiency. And our brain does the same thing. Okay? We fire these pathways enough, and we develop efficiency. This can work for us, or this can work against us. So we have negative plasticity. So if I had a stroke and my hand does this, my brain starts plastically remodeling to this tone unless I start working against it. Now, if I go to therapy for 30 minutes, an hour, 2 hours, and they work on my arm, and then I go home for 20 hours and I do nothing, did I get more negative plasticity or positive plasticity? I got more negative plasticity. And this is why it is so important and why my office, okay, why we are so big on doing home care, because I love spending time with you, I do. But in order to get you there, in order for you to really make these positive neuroplastic changes, these things need to be happening daily, like multiple hours a day. And if you just think about it like a seesaw. We need more on the positive plasticity side than the negative plasticity side. And that's hard. I know, it's hard because it's extremely time consuming, and you do still have to feed the family, and you do still have to go to the grocery store, and you do still have to do all the things that you do. So I promise, I hear you, I do. I'm just delivering the information, okay? Don't come torch my truck later. I love my truck. Okay, again, there's research on this stuff. Every time I talk about something, I just want you to know I'm not making it up. So, as a result, negative learning creates negative neuroplastic brain changes, resulting in neurodegeneration, which feed back to worsen behavioral impairments. Environmental and personal factors are posited to modulate the impact of changes in functioning on participation. Okay, and again, these processing changes result in brain changes, which in turn result in further disuse, perceptual compromise, and reduced neuromodulatory control. Perception is our reality, and that's a whole nother topic that I wish I had time to speak on, because how your brain is functioning, whether you are the injured person or you're the caregiver, how you're perceiving your environment is based on the functional state of your brain. And like we already talked about, there's several things out there that can affect the functional state of your brain. Like Dr. Jerry Levine's going to talk about compassion trauma and how, you as a caregiver can actually have some perceptual compromise because of the trauma to your brain from taking care of your loved ones. So I highly encourage you, please, 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 Dr. Jerry Levine, listen, she is an extremely sought-after psychologist. She is world-renowned, and she's here. Seriously, go see her, okay? She's one of the most humble people you'll ever meet, okay? So she'll actually be hanging with us in our room. So, all right, so what do we do about this stuff? So we already talked about the vagal system, and like I said earlier, developmental functional neuroscience, my opinion, is the most innovative form of healthcare on the planet. I'll talk to you about that till I'm blue in the face. I'm very passionate about it. I spend countless hours trying to spread this through the globe, okay? Because I've seen it change lives. I see kids walk and talk again. I've seen people that were suicidal that now come to me and thank me because they have a life, okay? I see this where people were in such terrible pain syndromes, you name it, okay? I see it, and so I'm passionate about it, right? But what does this look like? Well, it all starts with the exam, and this is based around the Melillo method. Again, Dr. Robert Melillo, he was a pioneer in this, okay? We examine the sensory systems, the primitive reflexes, the postural reflexes, core stability, vestibular system, eye movements, and cognition. And then guess what? Therapy is defined by that exam. Doesn't that make sense? That just makes sense, right? So when you go to the doctor and they do this wacky exam, they pull some labs, they scan your head, it's kind of hard to draw therapeutic conclusions from that information. They're just kind of throwing darts. That's sad. So therapy is defined by our exam. If we find altered sensory systems, we're going to address it. What if you can't feel your foot, right? What if you can't feel your foot? You need to address that first, because if I'm trying to rehab a primitive reflex, but there's no sensory component, that's important, right? Not only that, but if we have primitive reflexes still intact, which, by the way, those reflexes are there to develop the brain. So it's our inborn mechanisms to develop the brain. So we need to leverage those and use those. So if they're still intact and we ignore them, and we just start flipping someone in a gyrostem and start doing eye movements and all these types of things, but we still have primitive reflexes intact and we do not have adequate or balanced postural reflexes, that's not how the brain was developed. That's not how the brain was made to develop, okay? So again, we're just going back and going, how are we supposed to grow and mature and develop? This is how. This study just came out. I love it. It's fantastic. I've been talking about this stuff for a long time. I have a pretty long history with using laser therapy on the brain. Been using it for 12 years on the brain. People used to call me crazy. They still do, but that's okay. But we get people better, and that's all that matters. So look, it can be concluded that light-induced mechanisms with properly optimized light parameters have the capacity for neural cell regeneration and thus can be successful treatment for incurable neurodegenerative diseases. I should just throw the mic behind my shoulder and walk off the stage, but I won't do that. So that's a pretty heavy statement coming from the literature, right? Treatment for incurable neurodegenerative diseases. Dang. What's that? It's crazy, man. It's good stuff. Okay. Finding the right team, and I'll leave you with this. And I think that I'm going to be preaching to the choir on this one, but look, guys, if you don't have the right team, for example, I've heard people call me and they're talking about, well, this guy wants to do X, Y, and Z and all this kind of stuff, but when I'm hearing these stories, they're really just trying to generate more business within their practice. And look, when I'm working with kids, it's for the kid, okay? And so if I'm hearing these things, I'm going to call it out. Because listen, Dr. Hartz is the expert in H-spot. I'm not going to pretend to be the expert in H-spot. I'm not. Dr. Profrock's the expert in stem cells. I'm not going to pretend to be the expert in stem cells. You understand that? My passion is functional neurology. That's what I do. You see that on stage. So I'm not going to go out and try and do all these things and be the hero in all these realms. That's not how it works. I can't do everything like that, right? I can't be everything, okay? So you have to develop a team. So look, for HPOT, you got your hyperacute and acute care, and I know it applies to more than that, I know. But Dr. Hartz is the man. Laser therapy, look, we got it down, guys. I don't care what it is. I know the parameters that work. I know the parameters that don't work, okay? When someone says, oh, well, can I use XYZ modality? Look, all photons work. You're going to have benefit, but I'm telling you, the things that we've developed and the things that we've, but we should have had another study going on in Cuba, but COVID kind of squashed it. We will get it back up and running. But no one's looked at lasering the brain as much as myself, except for the team out of Harvard, which I have communication with, okay? Developmental functional neuroscience. Again, I'm the Austin Center for Developing Minds, and I'm sorry we're booked out for a long time. I'll try to suck, but we can't suck. We have a pretty cool team, and we get really good results, but look, we have others. Again, I have a consulting service where we're starting to teach and train and coach and all these things so that we can provide services to the world. So just let us know if you need help finding someone. Again, stem cells, Dr. Profrock's the man. Trauma therapy, this is so important, guys. And here's the thing. Last night I was laying in bed and I was like, if there's one thing that I can tell you, what would it be? And I'm sitting there going, how fancy can I be with lasers? No. What about this? No. Look, here's the one thing I can tell you. And I just had this image of when a plane starts to crash, all the oxygen masks come down. And they tell you what? They tell you put the oxygen mask on yourself, right? On yourself. And why is that? Is it because you're selfish? No. It's so that you can then take care of others. If you're suffocating, you won't be able to take care of your loved ones. So if there's something that I can tell you, caregivers, get some help. Trauma therapy is real. You have been through the most horrific things anyone could ever imagine. And I know it because I get to hear the stories, guys. I hear the stories every day. So much so that my own brain became conditioned. And every time I would go out, I would see all the ways my kids could get hurt. You see how that works? And so my brain became conditioned. So I called Jerry, she hooked me up with a therapist, and I started working through that for my own brain. It's so important. If you're going to take care of others, you have to take care of you. And it's not a selfish thing. That is so you can serve your loved ones to the fullest potential. Okay? And then functional medicine and nutrition, which I think we all know is so important. Okay? I just want to leave this picture up here. I am so fortunate to work with Kristen Hughes, with Dr. Jasmine. Guys, I walk into the office, I don't know how we ended up together, but it's fantastic that we did. Just so you know, fun fact about Jasmine, she can fart on command for Robert Boyton. Yeah, that's a true story. I don't try because I'd need a change of underwear, but I'm telling you, it's a team effort, guys. Here's a little look into what we do.
I've been waiting for somebody just like you, hoping, praying, run away to something new. My mistakes brought me to this place. I had to fall to get to you.
Cody, how many push-ups can you do now? That's weak. Good job, Cody. That's awesome. Oh, man. I love what I do, guys. Absolutely love what I do. If we have time, if you don't mind. I love this story, guys. Just listen to the story.
31 weeks. He's a triplet, and he got an infection when he was 10 days old, and he started having seizures, and then he had a brain bleed because of lack of oxygen, and then we were told like I remember telling the doctor what can we do for him, and he was like, only pray, like it's the last resource, pray and hope he will live. We were starting traditional therapy since he was 10 days old, after he went out of the emergency, and we continued therapy and nothing changed, and they diagnosed Leo with spastic quadriplegia when he was 6 months. So we started looking for options. Like I was okay with the diagnosis, but not with the prognosis. Like I was like, I have to do something about that. So I decided to look for other options, and I found a group in Facebook that is called Brain Injured, Hope for Brain Injured Children, and then there was the name of Dr. Crawford like in every post, so I have to find out who he was and how was his methodology. So I started researching, and I bought my laser without, I saw so many good comments about the Dr. Crawford and his team and all that. So I decided to buy the laser, and when the laser came, we started a protocol with Leo, and what had been working for 8 months started working in 2 weeks. So his muscle tone began to change a lot. He was happy for the first time. Like, he was always crying and no one could touch him. Like, he was super sad with no expression. And then we bought the laser, and with 2 weeks he was other baby, completely different. He started smiling a lot. He started babbling a lot. He moved his legs for the first time. So we were really like anxious to come here and see what the intensive will bring us, and we are really happy. Like he has advanced so much, and like he has advanced what he didn't advance in 12 months. The laser did much more than any other therapy. So yeah, we will stick with Dr. Crawford and his teams until Leo goes to college.
It's amazing stuff, guys. So again, you know, her story is just so powerful. You know, just like everyone here, everyone has a story, and that story can be used. And I want to, you know, just tell you, look, use your story. Let's get more of these stories out to the world, right? Because they just told her, they said, go home and pray. We can't do anything for your kid. I wish we would have had footage of Leo before we worked with him, because it was, you know, it was a mess. But, you know, these are the things that I get to see and that we all get to see. And it's just so amazing. So, again, thank you for your time. I'll be in the room. Come talk to us. Look forward to seeing you. Thank you.